All right. I wanted to just take a second to thank you, Dr. Franklin, and your site for allowing me to come and conduct your SIV for the Best One clinical study. We're excited to be working with you guys. Just to do a quick overview of our agenda, we'll do an overview of the study drug, review the protocol, go over some safety reporting requirements for AEs and SAEs, go over the investigator obligations as well as study timelines, take a look at the study procedures and timelines, as well as go through our monitoring expectations. And then at the very end, if you guys would, I'll ask you to give me a site tour. I will try to keep everything on schedule and make sure we're going in a smooth and timely manner. But please feel free to stop me if you have any questions at any point. And just to go through and make our introductions, I am Hannah White. I am a CRA with Great One CRO. I will be your main point of contact for the Best One study. I will report all your questions to Big Pharma Pharmaceuticals, who is your sponsor. They will also be providing your IVRS system for the study. And then the one other vendor we do have for this study is Primo Central Laboratory, who you'll send all your lab specimens off to. And of course, I have had a little bit of time to interact with you guys, Dr. Franklin, as well as Jane and Sally. Thank you again for being here. To just jump on in, we'll start off with an overview of the study drug. The drug itself is a pill form. Earlier studies used a small compressed tablet form. It was tolerated up to a dose of 300 milligrams given once a day. The drug is almost completely metabolized by the body. This does reduce the risk of a hypotensive effect. However, there were a couple patients in a previous study who were on a thiazide diuretic, as well as being on the highest dose of Best One that they could be on. They did have to be hospitalized with some mild hypotension. There have been some observed changes in kidney function. These can be expected some in people who are already susceptible, so people who already had some kidney disease, mainly by way of either unilateral or bilateral renal artery stenosis. We did see some increase in some markers for kidney dysfunction, being blood urea nitrogen and some serum creatinine increases. There may also be some non-explanation for some renal dysfunction in people who didn't previously have it. However, this typically only occurred in people who are already on a concomitant thiazide diuretic. And again, same thing, just the mild transient renal dysfunction, increases in the blood urea nitrogen, serum creatinine, and also some increases in potassium will be some things that we'll watch for with this study drug. Patients in previous studies who received either Best One or placebo did report some generalizable adverse effects, side effects, if you will, nausea, vomiting, headache, dizziness, fatigue, loss of taste, some fever, some stomach pain, and some mild confusion and lightheadedness. One side effect to note was a bad taste in the mouth. In the previous study, there was a compressed tablet used. However, we have now newly formulated this tablet into a film-coated tablet, and there's been no issue with bad taste. One thing to note for you guys and also to note to your patients is that these side effects generally resolved on their own within the first few days of being on the drug. So they really weren't anything that persisted it for a long period of time. There was an instance of a more elderly European lady who was on the high dose of Best One, which again is the 300 milligrams. She had to be hospitalized for symptomatic hypotension after her 5th dose of the drug. Symptomatic meaning she had some dizziness, had some extra fatigue, maybe even had an episode of syncope, not sure exactly, but was symptomatic with it. This was assessed by the investigator, and who did think that the drug did play some role in causing this event. However, it is important to note that this lady had also, just in the preceding days to the event, had a flu-like illness, and was dehydrated because she had been having some nausea and vomiting, that sort of thing. So that likely played a role as well. You have a question, Dr. Franklin? The half-life of best wine. That I am not sure. I will for sure follow up with the medical monitor for you on that, though, and get you an answer as soon as I can. All right, thank you. Moving on to the objective of the study, we are comparing the efficacy and safety of best one to that of another drug, which of course is the standard for hypertension care. Of course, all the patients in this study will have hypertension. There is one primary endpoint as well as a couple of secondary endpoints. The primary endpoint is to assess the change in blood pressure from baseline, from when patients were not on the drug, to the point in the study where they stop having changes in their blood pressure, and that probably will be towards the end of the study, the end of the dosing interval, which is 6 months. That will be an absolute change that is measured, and you'll compare the changes in the best one group to the changes in the control group, which will be on another drug. The secondary endpoints for the study will be the time it takes to reach that antihypertensive effect in both groups, of course. And then we will also measure the drug levels in the patient's blood by way of just those PK draws. This is, of course, a double-blind study. You guys will not know what arm each patient is randomized into. They themselves will not know, nor will I or any other member of the team. There is positive control, so no placebo, and again, 2 arms, being either the IP best one versus the positive active control, another drug. This is being studied in 300 patients, again, with hypertension. How the drugs will be administered. If the patient is randomized into the best one arm, they will take best one once daily and then placebo once daily. So best one probably in the morning and then their placebo pill at night. This will continue on for 6 months. Another drug they will take twice daily. Of course, that placebo in the best one arm is used to match and keep everything masked. Another drug will be taken again twice daily, once in the morning, once in the evening, and for that standardized 6 months. You have another question, Dr. Franklin? Of course. Okay, as far as enrollment goes, so there are 300 patients total in this study. The study has 30 sites, and the team is asking that each site enroll 10 patients over the course of 10 months. And more, do you want to know if you can enroll more? Yes, you can actually enroll more. You can enroll up to 20, but no more than 20. Of course, you're welcome. All right, moving on, we'll go to some inclusion criteria. Male and female patients are included, ages 18 to 55. Females, of course, have to be on some form of birth control or be non-childbearing potential. Patients, of course, have to have hypertension, and hypertension in this case is going to be defined as greater than 150 systolic over 100 diastolic. This has to be documented and has to be present for at least a month prior to the patient enrolling in the study. Moving on to the exclusion criteria, patients with a BMI greater than 30 will be excluded for this. If the patient is not able to come and attend visits for the study, if they have any history of fainting or postural hypertension, meaning they get dizzy when they go from seated to standing, anything like orthostatic hypotension, then they will be excluded. A patient who smokes tobacco, be it a cigarette or cigar of any form, will be excluded. And then anybody who refuses to give informed consent. If anybody has a known history of renal failure or elevated creatinine, they are excluded. Any known history of liver disease or liver enzyme tests such as ALT, AST, or bilirubin. Patients who are on a concomitant thiazide diuretic, most specifically or most commonly hydrochlorothiazide, that will be excluded. Patients who have taken another experimental drug within the last 30 days must be excluded. They can, of course, wait out that 30 days to see if they then can enroll. Patients with a known allergy either to the IP-BEST1 or to another drug, or then patients who have any significant health issues. This is typically would be up to the PI discretion if he feels they have anything going on that may interfere with their study involvement. As far as recruitment timelines, this kind of goes back to your question, Dr. Franklin. We will have 30 investigative sites in this study. The overall study target of enrollment is 300 subjects in 10 months. So you are targeted at enrolling 10 subjects at this site. You'll randomize using the IVRS system provided by the sponsor, and then you will also use the IVRS to register subjects who are either screen fails or who discontinue from the study. So just takeaway there, everybody does have to be registered in the IVRS system. All right, so let's take a look at some of the study assessments. So one of the big visits will be that screening visit, initial day 0. At that visit, you will conduct a full clinical history with the patient, go over any information about any heart history they have. You, Dr. Franklin, as the PI, will conduct a full physical. There will be an electrocardiogram done, pregnancy tests for any women of childbearing potential. You, of course, will get measurements for height, weight, blood pressure, pulse, respiratory, all the vitals, and then blood samples for hematology, chemistry. The PI, of course, you will review and sign all those lab reports as they come back. And then there will be a blood sample for drug level measurement at baseline before they actually take any drug. All of these procedures help us to prove that these patients do indeed qualify for the study, and at some level come back and support one of the inclusion or exclusion criteria that we are looking for. Moving on past that initial screening visit, if they meet all of the inclusion-exclusion criteria, then we will be able to actually actively enroll them in the study. So for the first month, they will be coming to you guys frequently, once a week. So you'll get pretty familiar with these patients. At each visit for the first month, done weekly, and that will be days 1 through 28, you will do a blood pressure measurement. Dr. Franklin, you will be required to do a brief physical exam, and then you'll again do blood samples, and then those PK samples for drug level measurement. Then these same procedures will be conducted again, but instead of being conducted on a weekly basis after day 28, you will go to a monthly basis, and this will be done from weeks 4 to 24. So that will be end of month 1 all the way to month 6. And then at the end of study visit, there are only a couple procedures that have to be done. Reason for discontinuation, completion if it is end of study, and then a specific reason for discontinuation if it is an early term visit. And then you will, of course, just take that one last blood pressure measurement. All right, all laboratory assessments, as stated there in the beginning, will be sent to Primo Central Labs. All lab reports should come back to you within 48 hours. If there are any queries that come up with the lab report, be sure to just answer those as soon as you can so you don't have a delay in getting your lab reports back. Dr. Franklin, of course, you will review everything for any clinical significance, ensure any abnormals are followed up on, or see if anything needs to be recorded as an AE. All right, speaking of AEs, let's talk about our safety reporting. So an AE, I'm sure as you guys already know, is an untoward medical occurrence that happens while the subject is in the study. It can be due to the medicinal product, or it may not be related at all. So as the PI, you will assume or assign a causal relationship. So it can be unfavorable or just an unintended sign. Can also be, as we just stated, a clinically significant laboratory finding. Just anything that is causing the subject some level of discomfort. These, of course, are going to be new illnesses that happen during the study. They're not going to be anything that was reported as being part of the patient's medical history. However, if that patient does have a change in baseline to the worse for one of their medical history events, then that, of course, will be considered an AE as well. AEs, those will be occurring during either the drug-free period, so that'll include both the screening and the follow-up periods, or while they are on the investigational product. One thing to note is that lack of efficacy. You're not seeing a change in their blood pressure. That is to be expected, and unless it is severe and causes the patient some discomfort or harm, that is not to be considered an AE. The AEs will be collected from the time the patient signs informed consent all the way to the end of study visit. These are collected on a cumulative form, and they're not collected in real time. They will be followed to resolution, so continue to ask the patients about the event until they tell you that it has resolved. And if in the case of an abnormal lab, it is considered persistent or still ongoing until that value has returned to normal, or if it is stable. If there is a medical intervention required, meaning they seek care from a doctor or have to go to the hospital, all measures should be used to make sure that everything is done appropriately and that the patient is cared for. Dr. Franklin, you of course will assess the causality and the relationship to IP for best one to see if it does happen to play a role. And again, as I just mentioned, AE is collected aggregately. All right, now as far as serious AEs go, SAEs. So SAEs are defined as an untoward occurrence that either results in death, hopefully that will not happen here, is considered life-threatening, meaning that the subject is at a potential risk of death or severe harm, or if no intervention is given, then they could have died. If there is hospitalization for at least 24 hours, or there's a prolongation if they're already in the hospital, or if it results in, again, in significant disability or incapacity for the patient. If by chance somebody becomes pregnant and the drug causes a birth defect or anomaly, this of course would be a serious AE as well. There are also any other important medical event deemed by the investigator. These all have to be reported as serious AEs. As far as reporting the SAE, I have always with me a copy of the SAE report form. I'll provide that for you today, and if you ever need extras, feel free to reach out. I'll be more than happy to send those over. Per guidelines and regulations, you do need to report the SAE to the CRO within 24 hours of you finding out about it. Even at the time, if you do not have extensive information, just report with any information that you do have, the summary of the SAE. We will send some follow-up data information back and forth to just clear up anything that needs to be cleared up. And then the sponsor will make the determination of causality from an SAE. So that actually does not fall on you, Dr. Franklin. That is the job of the sponsor. And then the sponsor has between a week to 2 weeks to get this reported to the FDA. If some unblinding is necessary, then there are some envelopes that can be provided to you guys to help with this. All right, Dr. Franklin, this is again more for you, but get information for the study coordinators as well. By signing the Form 1572, you agree to conduct the study according to the protocol. You also agree to provide oversight by personally conducting or supervising those who are conducting your investigations. You are also obligated to inform your patients or any persons that are on a control that these drugs are investigational. These are not actually meant to be considered treatments. And then you are also obligated to ensure that 21 CFR Part 50 is upheld, meaning that the IRB has approved everything and you have met all requirements per the Code of Federal Regulations. You are also obligated to report any SAEs to the sponsor that happen to comply with the Code of Federal Regulations as well. You are also, by signing it, agreeing that you have read and understood the investigator's brochure. This, again, will let you know about any potential risk, harms, or side effects that your patients may experience while on the drug. This will also ensure that all of your, by signing, you will also ensure that all of your associates, colleagues, anybody that is delegated a task on the study has been adequately trained by you and is informed about their obligations in meeting the study commitments. You are also, by signing, saying that you are going to maintain adequate source records, meaning that everybody will be to come back and look and see exactly what you have done with the study and with what patients. This, of course, will meet the requirements of the Code of Federal Regulations. You are also, by signing, saying that you are ensuring that the IRB you use complies with the Code of Federal Regulations as well. And you are also to report any IRB changes or changes in research activity. And then, of course, by signing, you are also just noting that you are complying completely with 21 Code of Federal Regulations, Part 312. All right, and again, just some more review of the Code of Federal Regulations here. As part of your investigator obligations, you are to conduct the study, again, according to the agreement, the protocol, and to apply with any FDA regulations. You are, most importantly, to protect the right, safety, and welfare of all the subjects that come into your care. And then you are to have active control over the IP itself. You are only to give IP to your study participants, and then you or your sub-I will directly supervise this. You are also to dispose or return per your SOP and per our SOP of any of your investigational product that is left over at the end of the study. You will also ensure, again, that the IRB complies with all of the Code of Federal Regulations requirements. And then if anything is needed as far as for initial counseling from the IRB or the study's continuing review and approval, you make sure that is obtained. You will also obtain informed consent from each subject that comes in for this study. Oh, excuse me, and I'll back up just a second, according to the Code of Federal Regulations as well. Did you have a question, Jane? Of course, as far as informed consent goes, okay, so you have a large Spanish-speaking population, right? Okay, so as far as getting an ICF in Spanish, that can be done. Once your ICF has been approved by the IRB, I do just encourage you to let me know as soon as possible, and then I can coordinate having the ICF translated for you. So I think that is something we definitely can do. Of course, you're welcome. And again, just some more summaries as far as Dr. Franklin's obligations per the Code of Federal Regulations, what you are submit to the sponsor, progress of the study, any safety reports as we spoke about, AEs and SAEs. You're supposed to submit the final closure of the study as well as any financial disclosures as well. You are responsible for maintaining accurate notes, accurate records about the study, about your participation in this investigation. You're supposed to make dispositions on the study drug and keep any case histories that may be relevant. You are to also retain these records and make them available either for monitoring review or if the FDA does come around for any FDA audits that may happen. Alright, so we'll jump back a little bit more into some more study procedures. So as previously mentioned, taking blood pressures, you'll all be pros at it by the time this is over with. So we are not doing just your standard setting blood pressure. There are going to be 3 different positions that your patient will have to be in for you to take their blood pressures. This is typically referred to as your orthostatic blood pressure measurements. So the first thing you're going to do is have your patient lay down in a supine position for 5 minutes. After that 5 minutes is up, you will ask them if they are left-handed or right-handed, and then use that dominant arm to measure their blood pressure with the device provided by the sponsor. You'll do this in triplicate, so you will measure it 3 times in that dominant arm, and of course record everything on your source data sheet. After that's completed, you will move your patient to a sitting position. They will then have to sit for 5 minutes, and then you'll complete that same procedure again, just as you did when they were in the supine position. And then you will move your patient from the sitting position to the standing position. Tread with caution here, make sure they're not dizzy or anything like that. Have them stand up. This time you're only going to have them stand for 30 seconds. And then you're going to repeat that triplicate procedure. And again, make sure you record everything on your source data. You have a question again, Dr. Franklin? Of course, no problem. Okay, so you typically only do people in sitting position. Okay. Oh yeah, totally understand that. No, that is great, and I love your standard of care and making sure that everybody has a good solid blood pressure. However, just because this is defined in the protocol, this is what has to be completed. If you have any questions or want me to follow up with the medical monitor and get some more reasoning behind it, I will be more than glad to do so. Is that okay? Okay, perfect. Alright, so let's talk a little bit about actually randomizing your patient. So again, as stated before, you will use the IVRS system provided by Big Pharma. You will contact it after the completion of all the pre-study assessments. So after you get confirmation that everybody's labs are good and that they are okay to actually be on drug, you can bring them back in for that next visit to get drug. You will call this provided number. You will be prompted to enter your site number, answer a few questions about the eligibility criteria for the patient, and then you will be given a patient number. And that is really it's really simple and easy to use. And then as far as drug resupply, it will be sent to your site within 24 hours of an overnight courier. You will just call the IVRS system at that point as well to order your drug supply when needed. Alright, we're getting there, you guys. All right, let's talk a little bit about labs and sample processing. Again, your central lab is Primo Central Laboratory. Your lab kits will be sent to your site. If you have those already, please feel free to show me those later. The sample kits will be sent back to the laboratory. You will get results within 24 hours. The reports themselves do take sometimes up to 48 hours. So the PK, so those draws that you are doing to actually measure the level of the drug in the patient's blood, that requires a full SST tube. Of course, that will be provided in the lab kit itself. Just be careful. Don't just draw a half tube on those. Draw a full tube. We do prefer that you draw from the cubital area, so just inside the arm there. Don't prefer any hand sticks or things like that. Sequence of drawing the tubes really doesn't matter, and you can use a tourniquet if you would like. Please invert tubes to initiate clotting. You will need some ice when conducting your laboratory assessments. You'll have ice with you when actually drawing the blood from the patient. The labs will sit on ice while they clot. You will then transfer everything to your refrigerated centrifuge. It'll be set at 4 degrees and you'll spin it for 15 minutes. And then you will just transfer everything into the transfer cryo tubes and label everything with the subject ID. You will have 6 cryo tubes per 1 serum bottle. And then if you have anything left over, you can label and save for later. Make sure if you have anything that is less than 400 microliters, you label it as having less, and then again just store in that retention sample. That can be your save for later sample. Once you have everything decanted and everything labeled, freeze it in your minus 80 degree freezer immediately. Don't let it sit out for too long. And then you will be prompted by me or another member of the study team to ship all your samples. And then, of course, your freezer does need to be continually monitored to make sure there's no temperature excursions or things of that nature. All right, study timeline. So this study is slated to begin in January of 2020, so just a few months away now. We are looking at mid-month on the 15th. We will have 10 months of enrollment, with enrollment slated to be completed on October 15th of 2020. And again, you are to enroll 10 patients at your site. And the last thing I really want to cover with you guys throughout this study will be our monitoring expectations, as well as some information about your source documents and entering data. I will not be back for the first IMV until 2 weeks after you enroll your first patient. So as soon as you enroll your first patient, let me know, and we will get your first IMV set up. I will come at that point every 4 weeks depending on enrollment. So if we're a little slower to enroll, it can be spaced out some. If you are enrolling a lot of people quickly, I will definitely be coming at least at every 4 weeks. So again, everything will be scheduled in advance with you guys and confirmed via writing and email. I will be sure to have timely follow-up letters with you, and they will have any action items that we need to address or anything that we discussed at the visit. I will require about 8 hours on site, so a full working day on site for an IMV. We will also discuss consent processes, and your site SOP on consenting will be reviewed. We will do that at the first IMV itself. There will be an overview of the CRF completion and source document verification. I will start working on that hopefully as soon as you enter your first patient into the EDC system. We will also go over your query process at the first visit once we know exactly what you're working with and how much data you'll have. There will be, of course, the 2 types of queries you could get. Those automated queries data management queries that are manually sent, and then I can also manually send queries as well. And then we will review any potential for audits, we will review some study closeout procedures, and your record retention as well. Make sure that you have everything you need in the case of an audit. All right. So that is the end of the slideshow I have. Do you have any questions from anybody at this moment? Okay, perfect. All right, so we'll get wrapped up here and get ready for the site tour. Thank you, guys.